Let's continue with our kidney pathology playlist. In this video, we're going to look at acute post-infectious glomerulonephritis. So we are still looking at the disease which affects the glomerulus. And these diseases are divided into two. We have primary glomerular diseases and we have glomerulopathies secondary to systemic diseases. We have already looked at minimal change diseases, focal segmental glomerulosclerosis, membranous nephropathy, and now we are on acute post-infectious glomerulonephritis. So if you want to know more about these diseases, just check in my kidney pathology playlist. You are going to find them. In minimal change disease, we said we have a normal glomerulus here. So for anything to be filtered from the blood capillary to into the Bowman's space, it has to pass through three layers. So these three membranes are the endothelial cell layer, the GBM there, which is the basement glomerular basement membrane, and also the slits of the podocytes. Okay, so those slits which are formed by the food processes of the podocytes. But in minimal change disease, we had some cytokines which are produced by T cells, which distracts those food processes, distracting these slits, those small slits which are there. That was the main feature in minimal change disease. And in focal segmental glomerulosclerosis, we had the main characteristic feature in this disease was that we observed sclerosis. We had sclerosis taking place in the basement membrane, and that led to podocyte food processes effacement, and we also had loss of proteins. Here, the loss of proteins was non-selective. It involved more than one type of proteins, but in minimal change, we only had one type of proteins which were lost. So the differences between minimal change disease and focal segmental glomerulosclerosis are on this table here. You can pause and review. The differences between nephrotic and nephritic syndrome are on this table here. So in nephrotic syndrome, we have proteruria. Now, this proteruria is within the nephrotic range. That is 3.5 gram or more. That is the nephrotic range. And in nephrotic syndrome, the proteinuria is less than 3.5 grams. That's why here edema may not be there. It may be there or may not be there. Hematuria, loss of red blood cells in urine. Here it is usually absent, but here it is present. Edema, here we can have generalized edema, which is called anasaka. Here we may not have edema. Why? Because the proteins which are lost are less. Okay, now today's business, we are going to look at acute post-infectious glomerulonephritis. So from this title here, post, that is post-infectious. So this condition comes post to an infection. So it comes as a result of a streptococcal infection. Okay, so in this condition, which is called acute post-infectious glomerulonephritis, this one is caused by glomerular deposition of immune complexes. Okay, so we have immune complexes. Mostly we have antigen antibodies which are formed. So those complexes will result in proliferation of glomerular cells. Okay, so as a result of these immune complexes which are formed, we are going to have proliferation of glomerular cells. We have damage to glomerular cells, and we also have infiltration of leukocytes, mainly neutrophils. Why? Because nephritis, inflammation. So there is inflammation there. That's why you have infiltration of leukocytes. So apart from streptococcal bacteria, we also have other organisms which are associated with this condition. So these other organisms are pneumococcal infections, and we also have staphylococcus or staphylococcal infection. So these infections are also associated with acute post-infectious glomerulonephritis. So apart from these bacteria, we also have other viral infections which are associated with these conditions, such as mumps, measles, chickenpox, and hepatitis B and C. So those are also viral infections which are associated with these conditions. So the typical case of streptococcal glomerulonephritis develops in child 1 to 4 weeks after he or she recovers from a group A streptococcal infections. And what we should know is that only certain nephrogenic strains, okay, can evoke glomerular diseases. Now, that was an introduction. Now, let's move on to the pathogenesis. How does this disease takes place? How does it happen? So, what we should know is that it is an immune complex disease. Okay, so it is an immune complex disease in which tissue injury is primarily caused by complement activation. So we have activation of complement system, and mainly the classical pathway of the complement system is activated. We have three types of complement systems, which are classical complement system, and we also have alternative and lectin pathway. So the one which is activated here is classical pathway, the classical pathway of the complement system. Okay, now the typical features of immune complex diseases are as follows. So these are the typical features of this immune complex disease. So here we are going to have hypocomplementemia, which is low levels of the complement proteins in the blood, and then we also have glomerular deposits of IgG, and have complement on the GBM. So we're going to have observed complement proteins on the glomerular basement membrane, and we have granular deposits of IgG. Okay, and we have low levels of complement proteins. Okay, now we say that immune complexes are formed. So for immune complexes to be formed, we must have an antibody and an antigen. So this antigen, since it is post to an infection, they are produced by these streptococcus bacteria. So these antigens are the streptococcal exotoxin B, and we also have streptococcal glyceraldehyde 3-phosphate dehydrogenase. So these are the two antigens which evoke this type of condition, where we have those antibodies formed against these antigens, and they get deposited in the GBM, in the glomerular basement membrane. Okay, so what happens is that those antigens which are formed, they are going to bind, or they are going to form complexes with the antibodies, and they're going to be deposited in the subepithelial space there. So in there we are going to have complexes which are going to be formed. Okay, so once they are formed in here, they are going to form what we call harms. Okay, they are going to form harms like that. Okay, so here what is happening is that we have these antigens, they have affinity for glomerular proteins. So once they bind to the glomerular proteins, then the complement system will be activated. Once it is activated, it is going to try to destroy those antigens there. In the process, it is going to cause damage to the glomerular basement membrane. Okay, now let's move on to the morphology. The morphologic feature, the most feature here which is observed, is the increase in the cellularity of the glomerular tuft. So the cells of the glomerulus are going to increase. They are going to there will be increased proliferation of glomerular cells. Then we have swelling of endothelial and mesangial cells. So these cells which are here, messenger cells are going to swell, they are going to enlarge in size, and then we're also going to have proliferation of the glomerular cells. And then apart from that, we have infiltration of neutrophils. So in the area of injury there, we are going to have neutrophils which are going to infiltrate, okay, and crescents are going to be formed. So crescents here, we are talking about increase in the layer of these cells here. So mostly here, the layer of these cells here is just one cell layer, but in this condition, what is observed is that we have proliferation of other cells forming a double-celled layer, and that is what we call crescent formation. Okay, so it is formed in urinary space. Under an electron microscope, you are going to observe these other features here, which are the immune complexes are going to be deposited in the in the subendothelial space, and we are also going to be deposited in the intermembranous or in the subepithelial space, forming humps. Okay, in that space there, that's where they are going to be deposited, or in the same podocyte food processes, and they're going to form structures like this. So these are what we call humps, something like that. So those are humps which are being formed here on the GBM. Okay, so clinical features. So clinical features of this, we have acute nephritic syndrome. So the nephritic syndrome here is acute, and that is the most common feature which is observed. Edema here is there, and we also have hypertension. So other characteristic features, we also observe gross hematuria. So since this is a nephrotic syndrome, so we're also going to have loss of red blood cells in urine, and the urine here is going to be smoke brown. Why? Because of oxidation of hemoglobin. So there is oxidation of hemoglobin. So instead of the urine appear bright red, it is going to be smoky brown. Okay, and also we have some degree of proteinuria. Okay, so proteinuria, and another most important feature here is that serum complement is low. Okay, the serum complement is low. Why? Because we also have destruction of the complement proteins, and we have another feature here which is anti-streptolysin O. Okay, we have anti-streptolysin O. Since this streptolysin O is produced by the bacteria, the Streptococcus pyogenes, then an anti-streptolysin O is going to be found in the blood serum, so that antibody can be found there. Okay, and in mostly 15 to 50 affected individuals develop what we call end-stage renal disease. So about 50% of most affected individuals will develop an end-stage renal disease, which results to renal failure. Okay, and that is over 1 to 2 decades. That is 10 to 20 years. That's when it's going to develop in renal failure. Okay, and this can also progress to be a chronic. Okay, and in children, progression to be a chronic condition is lower in children. So thank you so much for watching this video. Don't forget to like, subscribe, and leave your comment in the comment section below.